Start.
Namaskar and good evening, everyone. I welcome you all for today's webinar on New Era in the Management of Breast Cancer. And with immense pleasure, I would like to invite Dr. Chandra Gowda, who is Associate Director, Medical Oncology, BLK Super Specialty Hospital, New Delhi, for the welcome and introductory note and to set the ball rolling. Over to you, sir.
Thank you, Horizon. Thank you for arranging this short CME. So we'll be concentrating on the topic named New Era in the Management of Breast Cancer. So there will be two divisions. One, we'll be talking. There are two talks on the metastatic breast cancer by Piyush and Vineet, and then there are two more talks by Mukesh and Rajat in the adjuvant setting, early breast cancer. We'll be concentrating on ER/PR positive HER2 negative setting here in the four talks. So without much ado, I would like to invite Dr. Rati, who is the director and professor and head of the radiation oncology department at MAMC, the prestigious MAMC and associated Lok Nayak Hospital, to chair the session. Over to you, sir, Dr. Rati.
Thank you, Dr. Chandra Gowda. I welcome everybody to this evening meeting, and at the same time, my regards to you, sir, and all the esteemed faculty members and the colleagues who have joined for the meeting. See, breast cancer has always been, breast itself has been a very fascinating organ in the sense it is palpable. You can detect a disease, you can feel the disease, abdominal lump, it's difficult to feel. A lung carcinoma, it's difficult to feel, but here you can feel it. And during my tenure as an oncologist, I've seen these patients surviving for long years. That is just because that we can, make subgroups, like somebody's ER/PR positive or HER2 negative, and we have targeted therapy for all this. So today we are, I think, concentrating on hormone positive and HER2 negative disease. And we have experts like Piyush Bajpai, Dr. Vineet Govind Gupta, Dr. Mukesh, and Dr. Rajat Bajaj. So to begin with, we have Dr. Piyush Bajpai, who's going to be talking to us on changing the landscape of postmenopausal HER2 positive, hormone positive, HER2 negative breast cancers. There's a change in the paradigm, and so you need experts in the field who can guide you through the changes. The oncology is a dynamic science. The pace with which we are changing, nothing else has changed. We are changing every month or so. We get new molecules, and then we have new strategies, and some get established, some gets deleted from our memories. So Dr. Piyush Bajpai, you can please start your presentation. I welcome you to the podium.
You are muted. You need to unmute yourself. Your slides are visible, sir, but you are not audible.
You're not audible, Piyush.
You need to unmute, sir. You are muted still.
Is that okay?
Yes, sir. Very much.
So thanks again to the chairperson, and thanks to Dr. Chandra Gowda for this opportunity. And my role over here is to talk on the changing the landscape of postmenopausal HR positive, HER2 negative advanced breast cancer treatment paradigm. And I'm speaking in reference to MONALEESA-3, the updated results of this particular molecule, Crexana. Well, I start with a case study, and then how the approach to such a patient should be, And then CDK4/6 inhibitors, which are actually the paradigm changers, and along with endocrine therapy. The role of CDK4 inhibition in advanced breast cancer, well, CDK4 in particular is important, and the approved inhibitors which are there, then some NCCN guideline recommendations and choice between how to consider, pick and choose which one amongst the CDK4/6, which is always a difficult question to answer. Mona Lisa 3 study results, which are updated and presented last year, as well as now further follow-up data, and of course the conclusion. So I begin with case study, and she's a 60-year-old lady which walks into your OPD postmenopausal with advanced breast cancer. Now these are the set of investigations which were done. Of course, the past history was showing that there was lump in breast which has been sort of neglected 14 months. It has been there, and core biopsy was done, bone scan, and an ultrasound and mammogram was done. The clinical findings were suggestive of a 3 centimeter left breast mass, and palpable lymph nodes were present. Bony metastasis was present on the bone scan, and it was found to be a HR positive breast cancer. So the patient got actually palliative radiotherapy for the bony metastasis, and then aromatase inhibitor was started, letrozole, for 14 months. And now she developed a right upper quadrant pain, and on abdominal scanning, she was found to have liver metastasis. Now, this is probably changing, and that's why, such a patient, however, we do get to see at times where we are treating certain set of patients with single agent hormonal therapy, but most of the times, I think so, our practice has moved forward wherever feasible to give a CDK4/6 inhibition as well as hormonal therapy in partnering, partnering with the hormonal therapy. But over here, this is the situation, and the actual goal is not just to extend life, but to give a better quality of life also. So chemotherapy is a big no right now when we are talking about estrogen positive breast cancers, metastatic breast cancers. Quality of life is very important. So hormonal therapy and combination should be the goal. And the therapy should be offered to give a fine balance between efficacy and quality of life. So the goal can be achieved by oral tablet, then why chemotherapy? That's the main consideration. And you are getting significantly improved PFS with the combination. So endocrine therapy in today's date is a bit questionable alone in metastatic breast cancer. We have overall survival data also from the various trials available, which I would be presenting as well. So the combination is important. CDK4/6 inhibitor. Now, this particular subgroup of molecule has really changed the way we are treating metastatic breast cancer, ER positive, and CDK4 amongst the two is the main critical driver for HR positive or negative advanced breast cancer, and it is responsible for tumorigenesis and cell proliferation. So levels of CDK4 are upregulated more than CDK6 in the breast cancer line, and the inhibition of CDK4 has been shown to block the ability of breast cancer cells to form tumors. We know that these three molecules are available to us in practice: ribociclib, palbo, and abemaciclib. So these are the molecules which we are using, and not a very fair comparison amongst all the three trials, but you need to have information across the board. Then this is one table, and if you look at it amongst the trials available, Paloma 3, Monarch 3, and Mona Lisa 2. So here we have postmenopausal ladies in the last two, and women of any menopausal status were allowed in the Paloma 3. These are basically the Paloma 3 is where you find the endocrine resistance coming up, whereas Mona Lisa 2 is the treatment naive population over there. And median PFS as we can see, 25.3 months placebo group was 16 months in the ribociclib group. Median PFS was 9.5 versus 4.6 months in the Paloma 3. So this is what we see, but then we need to look into the hazard ratios, and that's what is important. And what we see is quite similar, actually. No statistical comparisons can be made. So NCCN guidelines for adjuvant scenario, what do they recommend is that you have a tumor less than 0.5 centimeter with lymph node negative. Chemotherapy is not recommended. Endocrine therapy alone is an option to reduce recurrence risk. When you have a heavy nodal burden disease, more than 4 lymph node positive, you consider systemic adjuvant chemotherapy followed by endocrine treatment. And in somewhere in between, actually, you need chemotherapy and endocrine therapy, or endocrine therapy alone, depending on the tumor bulk, and of course whether the patient is postmenopausal or premenopausal, that needs to be considered. To talk about the early phase data of these trials and rather the lab studies, it was found that the way the ribociclib would inhibit the CDK4 versus CDK6 was 8 times more as compared to abemaciclib was 6 times, and then palbociclib was just 1, and therefore you see more of a marrow suppression with palbociclib being used when you use palbociclib, lesser with the first two. So free drug concentration is also more, and probably this results in a better visceral control of disease pattern. And here you have the data of overall survival being present with the ribociclib, all the 3 green ticks over there. And this gives actually more confidence once you are using the drug. This is what the oncologist wants to see, that the overall survival, what it is. Abemaciclib also, there is a tick over there in the MONARCH 2 box. The MONARCH 3 results are pending. Hopefully they would be encouraging. But the overall thing is that, again, you cannot compare the 3 trials. It's different trial, different population altogether. But yes, it is definitely easy to convince and counsel the patient, and you show the overall survival ticks, and that becomes important. So this is what the Mona Lisa 3 trial was, that it took postmenopausal ladies, nearly 726 patients enrolled in both the arms, nearly 484. 2:1 sort of randomization, and then they were treatment naive metastatic disease, or they could have received greater than 1, at least 1 prior hormonal therapy was allowed. No prior chemotherapy was allowed for advanced disease. So the previous case that we discussed is rather eligible for this sort of trial, and ribociclib was used as the usual dose along with fulvestrant, and fulvestrant becomes important over here because here you are seeing some hormonal therapy treated population also. So primary endpoint was PFS, and that's usually the endpoint in these trials, the primary endpoint, because overall survival becomes difficult to analyze. However, it was the secondary endpoint. ORR was there, and clinical benefit rate, and safety and safety data was there. So Mona Lisa 3, it reported the longest PFS2 in combination with fulvestrant, and you can see 26 months versus 5.5 months when ribociclib fulvestrant was used as compared to placebo fulvestrant. There was a 20.5-month increment in median PFS. Well, again, longest reported overall survival, and this is almost after long follow-up, and it is 53.7 months. Overall survival with the combination 12.2-month improvement over there, with nearly 47% of the patients making it up to the fifth year. So that's very important. Well, Mona Lisa 3 showed a superior overall survival with liver metastasis also, and that's a very difficult subset to treat because of the rapidity. But yes, it did show its overall survival, rather, improvement over there. And this is the subset where you find endocrine resistance also. So it showed impressive results. And therefore, nowadays, we do talk about where there is impending visceral crisis, whether we can get away with using these combinations. So superior PFS and best overall response rate in patient with liver metastasis So it was seen with Mona Lisa 3. And because of overall response rate being present, that's why what I said that, you talk about doing it in impending visceral crisis also. And what we saw that in all the exploratory subgroups, actually the benefit was seen, and consistent delay in time for chemotherapy by nearly 4 years. So if you can use this combination, actually you are delaying chemotherapy, and that's preserving the quality of life of the patient, and also better chemotherapy-free survival outcome. So nearly 32.3 months chemotherapy-free survival as compared to 10.1 months in the placebo arm. Now, we talk about placebo plus fulvestrant compared to ribociclib plus fulvestrant over here in this particular study, and median time to deterioration. So once the patient starts feeling that, the quality of life is getting affected, and there is no much of a difference between addition of ribociclib and not adding ribociclib. So the overall quality of life is not deteriorating much with the addition, and the overall quality of life was pretty well maintained. The side effects, if you see that most of the side effects, except for the neutropenia, though grade 3 is 47% and grade 4 is 7%, you would see higher figures in the palbociclib study. But other side effects, if you see, are actually not many. In the grade 3, the toxicities are nearly less than 1%, most of it, and grade 4, hardly any toxicities in the combination. So it was well tolerated with the highest level of CDK4 inhibition, and that's what we saw. QT prolongation has been a concern always, but what is actually described, and we as oncologists really get perturbed with anything related to heart. But of course, this should be looked out for. But actually, most of our peer group would say that, this is more of a paper toxicity. But of course, one should look out and follow as it is advised stringently. The ECG monitoring should be done. So, of course, this makes things easier when you look at the side effect profile of these 3 drugs together, and also the overall survival data, which is at least available to us. The pointer shifts, to counsel the patient, things become easier sometimes to choose your drug. So to conclude that median overall survival was longer with ribociclib and the combination and the hormonal therapy in this particular study. And the benefit was maintained when ribociclib was given in both the first and second lines, and was maintained across most subgroups. Treatment with ribociclib had a positive effect on subsequent chemotherapy use, and safety signals were consistent with those previously reported for Mona Lisa 3. So I may talk over here and give it back to the organizers. Thank you, and any questions I have.
Thank you, Piyush. So we take the questions at the end.
Yes, sir, we can take the question. Yes, sir, we can take the question in the end.
Okay. Then I will invite Dr. Vineet Govind Gupta. He's Senior Consultant Medical Oncology at Artemis Hospital. So now we are going to be very rightly said, picking the right strategy with PIK3CA mutations in hormone positive, HER2 negative patients. See, this is a set of patients, who really benefit with the change in treatment strategies. Dr. Vineet, are you there? You can start your talk, Dr. Vineet.
Yes, sir, I'm there. So thank you for the very kind introduction and invitation. So I hope my slides are visible. So topic for this presentation is picking the right strategy for a patient with PIK3CA mutated hormone receptor positive patients. So PIK3, so the basic problem is that these are patients who are basically facing an unmet need in oncology, in that they tend to have more aggressive disease with poorer prognosis, and they need some kind of therapy which can target this specific biomarker. And thankfully, we have got this therapy now in the form of Pluvicto. So roughly 40% of patients who have got hormone receptor positive, HER2 negative advanced breast cancer, they have this mutation. And mainly it is a negative prognostic marker. Even I think many of us would have this experience that the patient who are having this mutation, when we treat this patient, we do realize that the prognosis is worse and they progress early, and disease shows more aggressive biology. And across multiple studies, it has been seen that PIK3CA mutation, it leads to increased cell proliferation, tumorigenesis, endocrine resistance, and overall a poor prognosis. So this means that this is a subgroup of patient who needs something better to target this pathway. So alpelisib, which is Pluvicto, it is a small molecule tyrosine kinase inhibitor, which inhibits the alpha isoform of PIK3, 50 times more potent than the other PIK3 isoform, and this is the main isoform which is involved in the tumorigenesis process, which is the primary oncogene. And the idea is that by targeting this oncogene, you can overcome endocrine resistance and improve the prognosis of the patient. So first question before we go into treatment is testing preference. So when should you test, who should you test, and what procedure you can use to test? So testing for PIK3CA, so actually over time, my belief in this has also changed. Earlier, what I used to think is it is better to change at a time of progression. But what I faced actually was that sometimes the block, by the time the patient progresses after frontline CDK inhibitor and hormone therapy, the block might be too old to yield effectively the desired yield. So although PIK3 testing can be done from blood, it is not the concordance is not 100%. So tissue remain the more important modality. And over time, I've started doing PIK3CA testing earlier. So number of mutations are there. You can do it via either you can do it via a RT-PCR panel, or you can do it via next generation sequencing, and it can be done on tissue or it can be done on blood. So what is the relevance of PIK3 mutation testing? It is that in PIK3CA mutant patients, you can actually give this drug, which is alpelisib, to improve the outcome of the patient. And this was tested in the SOLAR-1 study, which randomized patients who had got postmenopausal advanced hormone receptor positive breast cancer, who were identified to be PIK3CA mutation positive. And they were randomized 1:1 to alpelisib with the standard fulvestrant dosing versus placebo with the standard fulvestrant dosing, with the primary endpoint being PFS in the patient with PIK3CA mutation, and other endpoint being overall survival, response rate, and quality of life and safety parameters. So if you look at the primary endpoint, you can see that there's an early separation of the graphs around 2-month point, and the median PFS is almost doubled with a 35% lower risk of progression or death with the addition of alpelisib. So almost doubling of the PFS, doubling of the median PFS with this combination compared to placebo fulvestrant, which was the previous standard of care. This makes it an important change in the treatment paradigm. And you can see from the subgroup analysis that irrespective of the site of mets, like we discussed earlier, that liver mets have a poorer prognosis. But even if the site of the mets was liver or lung mets, bone only mets, previous CDK inhibitor, prior chemotherapy, line of therapy, or the type of resistance, across all treatment arms, there was a statistically significant and clinically significant benefit from alpelisib. Although you can see the line crossing unity at some point, the test for attraction were all negative. And the response rate, you can see that it was almost doubled. So in patient who had measurable disease with PIK3CA mutation, the response rate was 35.7 versus 16.2%. While in all patients with PIK3 mutation, it was 26.7 versus 12.8%. So a significant improvement in the response rate as well. You can see from the waterfall plot that almost 3/4 of patients had some kind of disease shrinkage, although meeting the 30% margin for partial remission was lower, like we discussed in the previous study. So let us talk about some practical aspect of alpelisib dosing. So generally the starting dose is recommended as 300 mg once daily, which is given in the form of 150 mg tablet into 2, and it is given with food. And as per toxicity, dose reduction may be required to 250 mg or 200 mg, as we will discuss ahead. So when we talk about the safety in these studies, what was seen is that the main side effect were these 4. So we had, if you look at the grade 3 to 4 side effect, you can see the most significant side effect was hyperglycemia, almost in 37%, that is more than 1/3 patient. There was grade 3 to 4 hyperglycemia, rash 20% of patients, fatigue in almost 5.3% and diarrhea in 6.7% of patients. So significant, these 4 side effects are significant side effects and they need special discussion. So the most important side effect is actually hyperglycemia, and it is an on-target effect of alpelisib because PIK3, by inhibition of PIK3, what happens is that it interferes with the glucose uptake into the liver and muscle cells, which lead to increase in circulating glucose. So it is an on-target effect and it is a dose-dependent effect. And it is actually the most important and common toxicity with alpelisib. So first thing you should do when you are recruiting a patient to alpelisib is make sure that their diabetes is, they are either non-diabetic or their diabetes is very well controlled. So in this study, they had to have HbA1c less than 6.5% and only 4% patient in this study, they had diabetes. So either don't use it in diabetics, or if you're using it in diabetics, be very careful. If you look at the alpelisib arm, you can see that a fasting sugar between 250 and 500 was reported in 1/3 of patients. So there was a significant proportion of hyperglycemia in this study. So this is the guideline as per the study for management of diabetes. So I find this chart very difficult to read. So I have made and I am following a very practical guideline. This is the guideline which I follow, and this is just extrapolated from the previous chart. So patient who develop fasting blood sugar between 0 to 140, you don't do anything to alpelisib, and you can either observe the patient or consider adding metformin and just keep an eye on the blood sugar. For 140 to 160, you can continue alpelisib with the addition of metformin. For 160 to 250, you can continue alpelisib, but if despite the intervention it fails to reduce below 160 in 3 weeks, you should consider cutting the dose of alpelisib. And the intervention is, of course, you need to add metformin, and you can add pioglitazone if metformin fails. If the patient has fasting sugar which is grade 3 or higher, that is more than 250 to 500, then you need to actually stop the alpelisib. And if the fasting sugar falls to below 160, usually it is expected to fall quickly. You can restart it and cut the dose by 1 dose level. And if it still does not reduce below 160, you are ideally supposed to permanently discontinue alpelisib. And you should involve the endocrinologist, give insulin, and give metformin and pioglitazone. And for very, very high diabetes like DK or hyperosmotic coma with glucose more than 500, you should stop alpelisib and reassess at 24 hours. If the sugar has improved, you can actually follow the grade 3 guideline that you can consider restarting after few days at 1 dose level lower. But if it remains high even after 24 hours, you should permanently discontinue alpelisib. And treatment, again, it is metformin, pioglitazone, and insulin. So just a practical guide to management of the hyperglycemia. Recruitment, the kind of patient you include is very important. Often diabetes is something which gets missed in a consultation. Before you start alpelisib, always you should inquire about the patient glycemic control. And the recommendation for fasting sugar control is once weekly testing for first 2 weeks and HbA1c at baseline every 3 months. Although practically, I am sure people would be testing more frequently in the beginning. And once a patient develops hyperglycemia, you may have to increase the frequency of blood glucose monitoring. So next, let's talk about the rash. So the rash was a very common side effect in this study. You can see, but one interesting thing was that patient who got prophylactic antihistamine, the incidence of rash was significantly reduced. So you can see that incidence of grade 3 or 4 rash actually reduced by more than 50% if you are giving the patient prophylactic antihistamine. So ideally, I would suggest that everybody practice includes prophylactic antihistamine to reduce the incidence of rash with alpelisib. The treatment guideline is that patient with less than 10% BSA should get topical corticosteroid with antihistamine, and patient with more than 10 to 30%, they should consider addition of systemic corticosteroid with continuation of alpelisib. Patient with more than 30% BSA should stop alpelisib with systemic and topical steroid. And once the rash is fading or it is inactive, you can restart alpelisib. So for the first recurrence, you have to restart at the same dose. And from the second occurrence, you can reduce the dose by 1 dose level. And if patient has any grade 4 toxicity, that is superinfection or life-threatening toxicity, it involves permanent discontinuation of alpelisib. So coming to diarrhea, so diarrhea we can treat as per grading. So diarrhea of in grade 1, you can just treat with symptomatic care and not require alpelisib dose adjustment. For grade 2 onwards, you should ideally interrupt the alpelisib dose and restart at a one step lower dose. Now, interesting thing about diarrhea is you are only allowed one dose reduction to occur. If diarrhea reoccurs, the guideline is to permanently discontinue alpelisib. So just something to keep in mind with diarrhea. The symptomatic care of diarrhea actually involves Imodium, appropriate diet, low residue diet, etc. So one thing which is very often missed when we prescribe drugs nowadays is drug interaction. So importantly, alpelisib being a drug with a narrow therapeutic index, you need to be careful about drug interaction. So CYP3A4 inducer lead to reduction in alpelisib exposure, and BCRP inhibitors lead to increase in alpelisib concentration. And alpelisib can also have impact on other drugs which are CYP2C9 substrates. So just a practical guide, strong CYP3A4 inducer include phenytoin, carbamazepine, and rifampicin, you might be knowing. While BCRP inhibitor are some commonly used drugs in the clinic, including pantoprazole and other PPIs, ketoconazole, and even lapatinib. So you need to be careful if you are thinking of combining lapatinib with alpelisib in HER2 positive, hormone receptor positive in off-label setting. So you need to be careful about this. While number of drugs are substrate for CYP2C9, so you need to keep an eye, for example, warfarin, torsemide, even tamoxifen, diclofenac, celecoxib, fluoxetine, various insulin secretagogue anti-diabetic drugs, lacosamide, losartan, Montelukast. So there's a big list. It makes sense to put the patient drug list into interaction checker before moving forward with alpelisib, because these drug interaction may become important for this kind of medicines. So in the quality of life analysis of SOLAR-1, a number of questionnaires were administered, and actually it was found that the quality of life and functional status were maintained over the course of alpelisib treatment, and there was no difference in overall mean change from baseline between the two arms. So overall, alpelisib was able to maintain the quality of life in patient over time. And even physical and emotional subscales, there was no statistically significant difference. So overall, they were maintained with alpelisib, and symptom management, there was a positive impact with alpelisib. So just to conclude, these are common mutations present in more than 40% of patients. And I think as time passes, I am feeling that we need to test earlier for this mutation, although my practice still varies. And these are drugs which specifically target PIK3CA mutation with doubling of PFS, doubling the response rate. And although side effect may be an issue, if you select the patient carefully, use prophylactic antihistamine, and monitor for hyperglycemia, rash, and diarrhea, most of the patients are expected to have a good outcome. So with that, I will end my presentation, and thank you for patient listening. Thank you.
Thank you, Dr. Vineet. See, that was a very precise, presentation on, and very right presentation for PIK3CA mutation positive patients. Excellent. No, that's what I said. We are evolving new strategies, but we have to be careful about the side effects and proper monitoring of these patients. Next we have is Mukesh Patekar. He is a consultant medical oncology at Fortis Hospital, Fortis Memorial Hospital, Gurgaon. See, aromatase inhibitors traditionally were for postmenopausal ladies. But when you do a ovarian suppression, then a premenopausal ladies, technically becomes postmenopausal. So there is this meta-analysis on aromatase inhibitors versus tamoxifen in postmenopausal women with hormone positive early breast cancer treated with ovarian suppression. So let's see what this analysis, meta-analysis of 7,000 odd women in 4 randomized trials suggest. Dr. Mukesh, you can start your presentation.
Thank you, sir, and thanks organizer for giving this opportunity. Let me share my slides, sir. So the topic allotted to me is It is a meta-analysis of aromatase inhibitor versus tamoxifen in premenopausal women with hormone estrogen positive early stage breast cancer treated with ovarian suppression. So this is a individual patient level meta-analysis of 7,030 women for 4 randomized trials. We all know that tamoxifen reduces the 15-year breast cancer mortality by 1/3 in estrogen receptor positive disease as reported in Lancet 2011 publication. Similarly, aromatase inhibitor, which prevent the conversion of androgen to the estrogens, they are more effective than tamoxifen in postmenopausal women. So that data is was published in Lancet 25, and we generally follow this guidelines. Coming to the core topic of today's analysis, the AI may benefit premenopausal women treated with ovarian suppression. So coming to the this meta-analysis, it has included 4 randomized trials which were done in premenopausal women in early stage breast cancer. Those were treated with ovarian suppression test, and they have 2 randomization. They were either randomized to an AI inhibitor or tamoxifen. The primary outcomes were recurrence and cause-specific mortality analyzed by standard EBC TCG methods. For the sake of statistical significance, the two-sided p-value, it should be 0.05 for primary outcomes like recurrence rate, and for subgroup analysis, multiple investigation for that. The two-sided p-value was supposed to be 0.01. These are the 4 randomized trials were included in this meta-analysis. One was the Austrian breast and colorectal cancer study group, ABC-SG12. The other is TEXT, SOFT, and HOVE. These are the 4 randomized trials. So in next slide, I will spend some time to just understand the briefly how these trials were recruited the patients. Coming to the first randomized trial, ABC-SG12. So it was started in 1999. It recruited patient till 2006. There were around 1,800 patients were recruited. Most of the patients were hormone positive. Here, the goserelin was given along with anastrozole versus tamoxifen with or without zoledronic acid for 3 years. Here we can see that most of the patients were early stage breast cancer, having around 60% had a node negative disease, 75% patient had a T1 disease, and the median follow-up was 8 years. So this patient had a 3 years of therapy, along with most of the patients were very low risk. Coming to the TEXT and SOFT track analysis, these studies were conducted in 2003 to recruitment has happened till 11. 2,670 patients were recruited in the TEXT trial. The triptorelin was used along with exemestane versus tamoxifen for the 5 years. 60% of the patient received chemotherapy, which was optional if administered. It was given concurrently with triptorelin, AI, or tamoxifen started after completion of the chemotherapy. If the patient has not given chemotherapy, the AI was started around 6 to 8 weeks after starting ovarian suppression. 52% patient were node negative, median age was 43, and the median follow-up was 9 years. In SOFT trial, they were included 2,045 patients. Similarly, they have given triptorelin as a ovarian suppression, and the treatment was given for 5 years. 53 patients received adjuvant or neoadjuvant chemotherapy, and 60 patients had a node negative status. Median age was 43 years, and median follow-up was 7.9 years. Coming to the last randomized trial, HOVE study, which was initiated in 2004 till 2015. 710 patients were recruited. Triptorelin was given along with the letrozole versus tamoxifen for 5 years. The 63 patients in this study were given chemotherapy, whether neoadjuvant or adjuvant. And there were 55 patients had a node negative status, and median follow-up was 5.3 years. So these are the briefly the chemotherapy by trial. So I already discussed that for SOFT and pre-test, they had around 50 to 60% patient had received chemotherapy. In ABC, it was strictly limited to the hormone positive disease. Only 5% patient received chemotherapy. Coming to the primary outcome, risk of recurrence. If you look at the data for tamoxifen, at 5 years, the risk of recurrence was 10.1, and at 10 years it was 17.5%. In anastrozole group, the risk of recurrence at 5 years 6.9, and at 10 years 14.7%. So there was a net 2.8% gain with the risk of recurrence in AI inhibitor as compared to tamoxifen, and log relative risk was 0.79. This is the forward plots analysis, which clearly shows that the patient will, if you look at the data from the soft and text studies, here it shows the AR are better than the tamoxifen. In Australian BCSG group, it was not showing that significant between two groups. It was crossing the curves on both sides of the line of nullity. And in Hobo study, the benefit was favoring the AI inhibitor as compared to tamoxifen. So the relative risk was 0.78 for the all this combined analysis. Coming to the risk of recurrence by the years of the follow-up, if you look at the data from all 4 studies, so if you look at the 0 to 1 years, it's still benefiting the AI. At 2 to 4, 5 to 9, most of the they have shown the AI is better than tamoxifen. Coming to the distant recurrence, risk of distant recurrence is still at 5 years is 5.6 in AI inhibitor versus 7.1%. At 10 years, it is 10.2 versus 12.1%. At 10 year, gain was 1.9. Similarly, the breast cancer mortality, here we can see that the curves for the tamoxifen AI inhibitors are overlapping to each other. Still, at the end of 10 years, the 10-year gain was still favoring the AI inhibitors in terms of 0.4%. The relative risk was 0.01, and log rank two-sided was 0.94. So this is the breast cancer mortality by years of follow-up. So this is still favoring the AI group rather than tamoxifen. Coming to the subgroup analysis by any recurrence, the 13 analysis investigated the possible variabilities. Proportional reduction in the recurrence did not vary by the age, BMI, tumor size, tumor grade, histological subtypes, or presence or absence of chemotherapy. Coming to the recurrence by the nodal status, which is very much important in hormone positive breast cancer. So if you look at the node negative status, AI are favoring the outcome. Nodes 1 to 3, AI is still better than tamoxifen. Those patients who are more than 4 nodes, they are crossing the midline. And if you look at the combined analysis, AI favors the tamoxifen. There were around 4,231 patients had a node negative disease among the all 4 studies. And here, if you look at that 5 years, at AI inhibitor, risk of recurrence was 3.2% versus 6.3. At 10 years, it was 9.3 in AI inhibitor arm versus 11.7. And 10-year gain was 2.4% in node negative disease. Coming to the node positive disease in node 1 to 3, the 10-year gain was 4.8%. And at 5 years, still the benefit was there and it was maintained till 10 years. We all know that those who get aromatase inhibitors, the risk of bone fractures are more as compared to tamoxifen. Here we can see that 5 years, the loss is 1.2%, relative risk is 1.27. Coming to the non-breast cancer death, there were around 5-year loss of 0.3% in there was 0.5% at 5 years and 0.2%. So there was 0.3% loss of non-breast cancer death in a patient those are received AI inhibitors. So conclusion is using the AI inhibitor rather than tamoxifen in premenopausal women receiving ovarian suppression of ovarian function reduce the risk of breast cancer recurrence by the 21%, reduction in the distant recurrence, but no effect on breast cancer mortality or overall survival. The longer follow-up is needed in terms of the quality of life. Definitely was not mentioned in this meta-analysis because the ABC study have not looked upon the quality of data, and there was no increase in the non-breast cancer deaths and more fracture immune with receiving the AI inhibitor. So prophylactic bisphosphonate may reduce the risk of the bone fracture or the bone related complication, those patients reducing the A inhibitors. Thank you for giving this opportunity. If any question and down, we can discuss in at the end of the all the talks. Thank you.
Thank you, Dr. Mukesh. Now we move on to the next talk, which is by Dr. Rajat Bajaj. This is again, we are trying to, premenopausal women being technically converted into postmenopausal with ovarian suppression. And I don't know, in the previous talk also, they have not used radiotherapy for knocking down the ovarian function.
In this, the soft and pretest, they have option of bilateral oophorectomy or radiation. But most of the patient has received this triptorelin, sir.
Okay.
Yeah. So,
Thank you, Dr. Mukesh.
yes, sir.
So Dr. Rajat is going to be talking to, he is the consultant in medical oncology at Fortis Hospital, Noida. And again, a randomized comparison of adjuvant aromatase inhibitor exenestane plus ovarian suppression. See, ovarian function is very important. And if after suppression, then you give tamoxifen versus ovarian function suppression in premenopausal women with, I don't know. Let's see the update of the combined text and the soft trials. We are maybe deviating from the conventional teachings. So, Dr. Rajat, are you there?
Yes, sir. Good evening. I'm there.
You can start your
Can I have
presentation,
my
Rajat.
slide, please? Yes. Yes, sir. Please share my slides. Good evening, everyone. I thank the organizers for having me here, and I would like to talk about the use of ovarian function suppression and the use of AI versus tamoxifen in the adjuvant treatment of early breast cancer in premenopausal patients. And in the next 5 to 10 minutes, I'm going to talk about this text and soft study. Text and soft study, we all know and we've read these studies and we are very well aware of them. But then recently there has been an update which has come. And it is prudent to talk about how should we really take our adjuvant endocrine therapy in our patients forward from now on. So, like I said, there were these trials called soft text and the PERSH study. PERSH study later was closed early. And they were launched in 2003 to answer 3 basic questions, out of which 2 questions we are going to really discuss in the next few slides, which is the 2 questions are: what is the benefit of adding ovarian function suppression in patients who are having a premenopausal status, especially after chemotherapy as well? And number 2 is that when we are giving ovarian function suppression, should we really resort to using aromatase inhibitors, or are we okay using tamoxifen as well? Next slide. So previously, the results of 5-year and 8-year follow-up of soft and text have been shown. And what exactly has been shown is that addition of ovarian function suppression to tamoxifen certainly reduces recurrence, that is the risk of recurrence, as well as certainly reduces the chances of death, that is it improves the overall survival. Further, it also reduces the distant recurrence. But if you're going to talk about the difference between AI plus OFS versus TAM plus OFS, it reduces only the chances of recurrence. It does not really improve the overall survival.
Sir, your voice is breaking, sir. We can't hear you. Rajat, sir, we can't hear you.
Rajat, your voice is breaking completely. So probably have to.
Depending on what is the underlying risk, and those with lower risk as far as the clinically better
We can't hear you, Rajat.
Hello, am I audible?
Yeah, now you're audible.
Yes, yes. Sorry, there was a connection error. So 76% patients are there alive and they're still in follow-up. Next slide. Next slide, please. Yeah, so this is the trial schema of text and soft respectively. If you look at the text, it had premenopausal hormone receptor positive patients less than 12 weeks after surgery. They were randomized to receive the two types of hormone therapy, be it tamoxifen plus OFS or exemestane plus OFS for 5 years with a median follow-up of 13 years. And the question that was asked was whether tamoxifen is better than exemestane if you are giving OFS. If you can see, nearly about 2,500 patients were enrolled, out of which approximately 1,000 patients did not receive any chemotherapy. Very important point. If you look at soft, then again premenopausal patients less than 12 weeks after surgery randomization, and out of 3,000 odd patients, approximately 50% patients did not receive chemotherapy. There were 3 arms: tamoxifen alone for 5 years, TAM plus OFS, and exemestane plus OFS, again both for 5 years. Next slide. So now if we look at the patient characteristics, very interestingly, there were lymph node positive patients which were higher in the text study where chemotherapy was given as compared to patients where chemotherapy was not given. So which is understandable. If there is higher lymph node positivity, then we tend to give chemotherapy rather than not giving it. And if we talk about less than 35 years, which was kept as one of the high risk criteria in these two in this text study, there were about 12% patients who were less than 35 and patients who were given chemotherapy, and only 4% where they were not given chemotherapy. And next slide. No, please go back to the previous study. Previous slide. Yeah, and we cannot see the fonts over here for the soft, but the first column is for the soft without chemotherapy, and the second column is soft with chemotherapy. And again, if you see with chemotherapy, lymph node status, about 57% patients lymph node positive, and 20% patients less than 35 years of age. So very importantly, one has to understand that we are stratifying our patients according to the risk stratification. That is, if it is less than 35 years, or if the patient is receiving chemotherapy, then they are considered high risk as compared to patients who are more than 35, or if they are not receiving chemotherapy for various reasons. Next slide. This is the Kaplan-Meier graph for distant recurrence on the left side and overall survival on the right side for the soft trial with the overall population. And the question is the benefit of ovarian function suppression. So if we see the TAM plus OFS versus TAM, there is an absolute reduction in the distant recurrence as well as death. If we talk about the overall population in soft, that is, the OFS benefit is certainly there both for distant recurrence and overall survival, and this is there maintained in this current follow-up as well. It was there previously, remains maintained in this current follow-up as well. If we talk about AI plus OFS versus only AI, again there is an improvement in distance-free survival as well as overall survival. Again, this important difference remains there in this particular update as well. Next slide. So this is soft plus text overall population. You can see that is a 13-year median follow-up. And the question is about AI. If we are giving OFS, then are we justified using only tamoxifen with OFS, or we should always resort to AI? So very importantly, the absolute reduction in death is not a lot different. So what it means is that even if you're giving tamoxifen with OFS, it certainly is not wrong. It can still be given because the survival difference is not there. To me, the gold standard endpoint remains overall survival. Next slide. If we talk about the no chemotherapy cohort now in the soft study, and of course, we're talking about the current update, which is 12 years median follow-up, we see that if the patient is not given a chemotherapy, which means that these are not very high risk patients, we see that the difference in terms of the OFS is not great. That is, patients who were given OFS, they did almost same as people who were not given OFS, both in terms of distant recurrence-free survival and overall survival. You can see the Kaplan-Meier curves, they are hugging each other, and look at the 12-year update, 97% patients surviving versus 95.8% patients surviving. So not real difference there. So the question that we really ask ourselves, should we give OFS to all the patients? Probably no. We should select our patients, and if they are low risk patients, they can only be given tamoxifen alone. And remember, we are all talking about premenopausal patients here, and may escape the overall the ovarian function suppression. Why we really want to know that this is because ovarian function suppression comes with its own perils. So if we can avoid it in certain number of patients, why not? Next slide. And if this is soft and text, no chemotherapy cohort. And here also we see that if we talk about the AI versus tamoxifen, which is the question which was asked by soft and text combined, then here also AI is equal to TAM if you are giving OFS in such patients. And we're talking about patients where no chemotherapy was given, that is low risk patients, basically what we want to say. Next slide. But very importantly, the story changes once we look at a cohort where chemotherapy has been given, because these are high-risk patients. And like I said, in the patient baseline characteristics, they were patients who were mostly having a lymph node positivity. They were patients who were having an age of less than 35 years. And here, if you look at the further dissection, TAM plus OFS versus TAM, certainly TAM plus OFS was better in terms of both the recurrence-free survival and the overall survival. AI plus OFS versus AI, certainly AI plus OFS was better. So the message is loud and clear that if the patient is having a high risk feature, his patient is receiving chemotherapy, and it is certain that the patient has high risk features, that is why he's receiving chemotherapy, that cohort should be offered over ovarian function suppression. Next slide. And look at the chemotherapy cohorts of soft and text both. There were about 60% patients who were lymph node positive with a 13-year median OFS. Median follow-up. We see that the OFS, if we are giving to both the cohorts, the AI is better than tamoxifen. And you can see the Kaplan-Meier curves, they are separating. So again, very importantly, if we are giving AI over TAM, we should select our patients, and they should be high-risk cohort patients. Next slide. This is a very few number of patients here in these studies were HER2 positive, and it is seen that HER2 negative cancer patients, they were predominant in both the trials. If you talk about AI plus OFS versus TAM plus OFS, the absolute improvement in overall survival is about 3.3% at 12 years for people who are HER2 negative. Next slide. And this is a very, very interesting slide I could find. That is, they have really dissected the subgroups for the overall survival for both soft and text with HER2 negative cancers. We are only talking about in the current update, and we see that if we are having, like I said in the whole of my talk, that if we are having patients who have got higher chances of recurrence, the disease biology is not that good. There, the benefit of adding AI over tamoxifen or adding OFS in the given armamentarium of adjuvant therapy, adjuvant endocrine therapy works better. So if we have a lymph node positivity of 4 or more, that is N2 disease, it has got better meaning, or it has got more improvement with OFS and AI as compared to others. If you have age less than 35, it has more improvement. People given neoadjuvant therapy, they want OFS more than others. And if there is a higher grade 3, they need OFS or AI more than grade 1 and grade 2. Next slide. So this is the summarization of what I just discussed in the last few minutes, that if we have to talk about the distant recurrences and the deaths, they continue to improve with the strategies of soft and text, and ovarian function suppression certainly is an important tool that we should really resort to in our daily practice to improve the survival of patients who have got a high risk breast cancer, early breast cancer in hormone positive category. The current update of 12 and 13 years also says a similar thing. There is an absolute reduction at 12 years, which is clinically substantial in terms of both death as well as recurrence-free survival in OFS in the high risk category. But if we talk about the low risk, then the recurrence-free survival only is improved, the overall survival is not improved. So we should choose our patients wisely, and there is a very small cohort where OFS may not be given. We've talked about those as well, And this is what I would like to say about this particular topic. And thank you all for your patient listening. Back to the organizers.
So I hand over the stage to Dr. Chandragowda for the further discussions and conclusion of the today's meeting. Thank you.
Thank you, sir. Thank you, A.K. Ratish, sir, for chairing the sessions and excellently conducting the sessions. And then actually we started with the CDK4 inhibitors, Piyush, by an excellent talk by Piyush, how to select out agents and the update on Mona Lisa. And then Vineet, who writes strategy in PI King, and Mukesh, the adjuvant strategies, IAI versus tamoxifen was nicely covered. And then Rajat, so who is given excellent predisposition of tamoxifen versus AI versus AI plus overhead suppression. So one question to Dr. Rajat. So how long do you give overhead suppression in these patients?
Yeah, so sir, I think this is what is a very burning question nowadays about the duration of treatment, with the coming in of various studies in the last 7 to 8 years about the duration of treatment, whether it is 5 years or 10 years. One is about the duration of endocrine therapy, and the other is what is the duration of OFS. So the endocrine therapy duration can be debated. It can be 10 years, it can be 5 years. I really reserve my 10 years for patients who have, again, like I said, high risk, if it is lymph node positivity or if the patient is T3 and beyond. But the ovarian function suppression in all these studies, if you look at them very carefully, has only been kept as 5 years. There are no studies where the OFS has been kept as 10 years. And primarily the reason is that there are, like I said, a lot of disadvantages of a prolonged ovarian function suppression. So if you look at MS17R, it says that initial 5 years of TAM and then 5 years of AI brought a difference, but that 5 years of AI was with OFS and not the previous 5 years. So I would like to stick to 5 years of OFS, and I would like to stick to 10 years of endocrine therapy. And if that 10 years has to come, it has to be only tamoxifen in patients who are having high risk like lymph node positivity or a T3 or maybe both.
Thank you. I think I think you made it very clear. So we have 4 eminent speakers who spoke on all these, and thank you all for taking out your time for a busy schedule and making it to this short symposium on breast cancer. And back to Horizon, guys. So to wind up the session, thank you very much.
Thank you.
Thank you, sir. So can
Thank
we
you.
close the meeting?
Yeah, I can close the meeting. Thank you.
Okay, thank you so much, sir.
Thank you. Okay.
Good night, sir.
Right.
Thank you, sir.